Hello and welcome, everyone. Thank you all for joining us for this installment of Kornhauser Health Sciences Library's Diversity in Healthcare discussion series. I'm Jessica Petrey. I am one of two associate directors at Kornhauser in charge of our clinical services program. And I'm going to be moderating today's session. We do have a presentation for you called Beyond Compliance, Aiming for Accessibility in Health Education with two co-presenters. We've got Dr. Priya Chandan and Dr. Emily Noonan. And we will have Dr. Noonan will be presenting first, then Dr. Chandan. And we do have some time saved at the end for questions. If you want to go ahead and put those in the chat as you think of them, we do have people that'll keep an eye on that and make sure those do get as many of them as we can asked when it gets to the Q&A time. So we have a couple librarians who are kind of lurking in the background. Special thanks to Tiffany and Gina, who are the behind the scenes host moderators today. And there will be an evaluation put in the chat at the end to get your CE credits. So that should cover all the housekeeping details we have for today. And I will turn it on over to our presenters.
Hello, thank you. Can everybody hear me okay? Awesome. So as Jessica said, I'm Emily Noonan. I'm going to get us started here. And our goals for this session are to give you all a sense of what it looks like for people with disabilities who are in health education. We're going to talk some about different ways of understanding disability, so like conceptual models. So those are the things I'm going to focus on. And then Dr. Chandan is going to get into the difference between ADA compliance and best practices, and then thinking about how to improve accessibility for your trainees. So I want to start with where I'm coming from. I think most importantly, I come to health educations and disability and the issues involved in that from lived experience. So I'm on faculty in medical education in the School of Medicine. And so I spend a lot of my time doing research around health disparities experienced by LGBTQ people, people with disabilities, and curriculum pieces that can improve that. I also spend a lot of my time teaching and coordinating the social medicine piece of those preclinical years of medical school. I also have multiple disabilities, and that really informs sort of my thoughts and my experiences with this. So I'm going to start with a story that happened to me yesterday. It happened yesterday, so it feels very fresh, and I may in several years decide that it's a story that is actually not that interesting, but I think that it highlights the difference between compliance and accessibility. So I love to travel, and this weekend I was in New York City for a conference, and it was a lovely weekend. It was wonderful, and Sunday was my free day. And when I have time alone in a city, I often like to do things like go to a museum or go to a zoo. So I decided to go to the Bronx Zoo and see the otters mostly. Because my disabilities impact both the pain I experience and the amount of energy that I have, often when I'm going somewhere where I'm going to be on my feet for a long time, like a museum, a zoo, an amusement park, I will rent a motorized wheelchair or a scooter. So yesterday I got there. There are 3 separate entrances to the Bronx Zoo, and only one of them is where you can rent a scooter. So I got dropped off at one of the wrong ones. And so then that means you have to walk kind of across the zoo to get the piece of accessibility equipment that you need to be at the zoo and get through the zoo. But, not a great start, but that was okay. I get the scooter and, I'm having fun. I'm, off to see some animals of Madagascar and see the birdhouse. And it's a beautiful day. And I realized, the first building I go to, where the Komodo dragon is, that there are no automatic buttons to get into the building, and no door buttons at all. And usually layers of doors per entrance, right? So it's not just one door to get into the building, but one door, a little foyer, and then another door. And then within the buildings, understandably so, lots of doors between exhibits. So I had to wait at each door for somebody to come behind me. And this was every building. I did not counter, and I was there for 2 hours. I did not encounter a single building that had the automatic door buttons so I could let myself into a building. Asking strangers to open doors is not the end of the world, but it wore on me. I'm an introvert, and when you ask strangers to do something for you, it seems to invite commentary. For the most part, people were they were embarrassed that their zoo was not accessible, and that I was sitting there waiting, and somebody had to help me. But a few were patronizing. So eventually, after about 2 hours, I just thought, this is not fun. I'm not having fun. So I got back to the entrance, I got a cab, and I went to the airport. So for me, yesterday, sitting in LaGuardia for 3 extra hours was preferable to being at the zoo, largely because of the buttons. So this is a difference between compliance and accessibility. The ADA does not require automatic door buttons. It requires doors be a certain width, but anybody who is on wheels or pushing a stroller. I've also experienced this as a parent with a kid in a stroller. If there is no automatic door button, getting through doors is quite a barrier. I am also coming at this as a social scientist, so I want to situate that as well. I'm involved and do medical education because I believe that medical education is a health disparities intervention. As I said before, I teach a lot of social medicine, and what that means is that I believe and argue that our students, medical students, but also all health profession students, have to have an understanding of how society and medicine come together, or society and healthcare come together. This is also the idea that you have to go beyond the individual patient to think about society if we're adequately going to understand disease and illness. This is also the idea that health is produced, it's biosocial, biocultural, and that's a weird, fanciest word. But it just means that health and disease are the interaction between biology and the environment. And that, for me as an anthropologist, the humans, we are made up of both biology and culture. We are made up of our physical bodies and the society in which we live. This is also a position that treats healthcare as a human right. So I just want to sort of contextualize where I'm coming from. Priya, if you would like to, sort of introduce yourself and tell folks where you're coming from, go for it.
Sure. Hi, everybody. I'm Priya Chandan. I'm clinical associate professor in physical medicine and rehab. So to kind of situate where I'm coming from, so I do not have lived experience of disability. I have lived experience as a younger sister to an older brother who has Down syndrome. And I find sort of in my work that perspective really affects the way I do things, because the sibling perspective can be quite different from the parent perspective. And so I find that in my work that really helps my sort of bent towards advocacy, towards deferring to people who have lived experience, trying to elevate voices. I see my brother as sort of the best teacher that I've ever had. I guess that's sort of my background on a personal level. On a professional level, I also sort of come at things with the lens of physiatry, so physical medicine and rehabilitation, which is a functional approach to things, which we'll talk about a little bit later, as well as a health services researcher. So Dr. Noonan mentioned, health disparities. and how health education is truly an intervention to reducing some of those health disparities that we see. And that's particularly the case when we're talking about people with disabilities, as we'll tell a little bit more about as well. So I guess that's me in a nutshell. I'm a younger sister. That's how I've always been known, is like, oh, your uncle's sister, and that's me. So I'll let Dr. Noonan continue.
Thank you, Encore Sister. So I'm gonna give us just a little bit of sort of the Disability 101, some basics. Sort of the dictionary definition of disability, which I hope will complicate here, is a physical, mental, cognitive, or developmental condition that impairs somebody's ability to do stuff, certain actions or typical daily activities. And know that this is very broad. This is can be related to vision or communication, hearing, mobility, cognition, development. Many disabilities are invisible, as in you can't tell by looking at someone. It is important to know that disability is one of those, when we think about diversity, it's often one that we don't see, but is incredibly common. So about a quarter of adults in the United States have a disability. You will all, as health professions folks, you will care for people with disabilities. You may have disabilities. You will most likely have people in your lives with disabilities. Disability can be caused by a lot of different things. Sometimes it's at birth, so it's congenital. They can also be acquired, so an accident or trauma, or a disease process. And I'll also throw in there that things that are classified as disabilities may not actually impair someone's ability to be involved in day-to-day activities, but because they're differences or deviations from the norm, they're categorized as disabilities. This is from the CDC, a percentage of adults with functional disability types. So if about 25% of US adults have disabilities, about 13.7 have mobility difficulties, about 11% have cognition disabilities, or so this just sort of gives you a sense of like the range, right? And this is also going to add up to more than 100%, like more than 25% of all US adults, because some people have multiple disabilities. So we're counting multiple times here for some folks. We know that people with disabilities experience health disparities. So some of these disparities are related to things like isolation and underemployment and violence. So people with disabilities are more likely to be unemployed, victim of a violent crime, more likely to have health risk factors or health risk behaviors. So smoking, lack of access to physical activity, more likely to be obese. But I think for those of us who are in health educations, it's important here that these bottom two, so healthcare access is key. So of women who are supposed to be current with a mammogram, people without disabilities are more likely to be current with a mammogram. People with disabilities are more likely to not have medical care because of the cost. So we have some real disparities that are not just about a particular diagnosis or particular physical condition, but about access to the system itself. I want to throw a couple of terms at you that Priya is going to talk more about this, and I'll sort of touch on it. But the idea of ableism is key here. This is the idea that in our society, there's discrimination and prejudice against folks with disabilities. And this is the idea that being able, being typical or typical bodied or quote unquote normal is superior. So, as we'll talk about a little bit more, ableism is really rooted in this idea that people with disabilities require fixing. And this here, I want us to think about this as we think about health professions education. So the world wasn't built with people with disabilities in mind. And because of that, the world we live in is inherently ableist. I want to argue and have us think about the ways that health professions education is not built for people with disabilities in mind. And because of that, it is inherently ableist. And how can we challenge that? Also, as we think about disability, our topic here today is disability, but we would be doing a grave disservice if we think about it in a silo, separated from other social experiences or social statuses or identities. So keep intersectionality in mind, though our focus is disability. Class or social categorizations are interconnected. And Dr. Chandan's also going to talk a little bit more about that as well. So I said this a second ago, health professions education was not made by or for people with disabilities, and I'm going to say it's ableist. I think that there are two problems related to disability and health education that I want to highlight. First is the exclusion or lack of people with disabilities in health education, so in health professions. And then again, how health education thinks and talks and conceptualizes disability. So first, the issue of inclusion. Okay, so I don't mean to pick on dentists, and I am sorry to pick on dentists, I really am. But I found this a few days ago, what I thought was a really telling example. So I was trying to, I have information on students with disabilities in medical education, right? Because I'm in the medical school and I know that literature, pretty decently. So, I was trying to search for dental and nursing, and spoiler, could not find much data at all, sort of about the numbers of people with disabilities in those fields or in those educational programs. But I came across this on the American Dental Association website. So it's about supporting disabled dentists. And, and this is something I hadn't really thought of, but dental professionals are often at risk for developing disability because of repetitive movement, right? So, they can often develop physical pain because of the work that they do. But so this sort of quote from a website, I think is telling though. So the possibility of ever having a disability no doubt seems at best a remote possibility to most dental students, new dentists, and even practicing dentists. But disability happens, not often, but if you're the one it happens to, it can be devastating. So what strikes me about this is who's missing here. So this is really setting disability up as something that happens to people later in life. That you wouldn't have someone with a disability starting out in dentistry. Like I really think it makes people with disabilities invisible in terms of being trainees, being new dentists. They're really only thinking about it as something that happens sort of later in life as a consequence of aging or a consequence of the repetitive movements involved in dental care. If we think and talk about medical school, the number of students who identify having a disability has risen a good deal in 3 years. So from around 3% to closer to 5% in 3 years. And I want to highlight the disabilities that are most prevalent. This is contrasting DO schools and MD schools. For our purposes, I'm really just interested in the the types of disabilities that are represented. And here at U of L, we have an MD school, and the things that are most common are ADHD, psychological disabilities, chronic health conditions, or disabilities, learning disabilities, mobility disabilities, other functional impairment, and visual disabilities, and then being deaf or hard of hearing. I think we see there's a disparity here, right? So if 13.6% of American adults have a physical disability, but only 3% are in medical school. Only 3% of medical students. I'm sorry, if only 3% of medical students have disabilities, so that's a big gap. And I certainly don't expect it to be equal, but I would expect a little more parity than that, right? These are recommendations from the CDC about addressing those health disparities. And I'm interested here in the two that are in red. So strengthening the workforce and including people with disabilities in public health programs and practices. When the CDC says this, and when we talk about the workforce, I think we often think about increasing training so that health professionals can better care for people with disabilities, and this is key. But another piece is to strengthen the workforce by including people with disabilities, by really combining number 3 and 4 here. There are some great pieces out there about why it's important for health professionals with disabilities and scientists to be involved in health education, to be involved in patient care. And this is everything from having a similar lived experience to your student, similar lived experience to your patients, to pushing you to ask questions that you would not otherwise ask, you would not otherwise think of. And Dr. Chandan is going to talk with us more about sort of improve how to make training more accessible for your trainees. But I just want to highlight these are things that I think are places to start thinking. Like, if you're thinking about your program, ask, is it accessible? Do students feel like they can ask for help? Do your faculty feel like they can ask for help? Is there an understanding that the way that we care for our bodies, the way that we care for others and our family, these are normal parts of the human experience. Often in the workplace, we don't bring our physical differences. We don't bring, the burden of childcare, for instance. But these are very real and things that will make a health workforce and a health education program more inclusive and welcoming of people with disabilities. So the second problem I want to talk about is how health education thinks about disability. Now, again, my lens is really medical education here. But I think that from what I have seen and know of nursing and dentistry and public health, to some extent it also applies. So the work of health education is to produce people who can provide quality care for patients. They should doctors in particular should have a basic understanding, or an understanding of the basic sciences that underpin how the human body works, and the clinical skills to interact with patients, and the critical thinking skills to put things in categories. And human brains love categories, right? And I'd say that med student brains really love categories, or they have to love categories because that's what testing asks of them. The way that testing is structured in health education really requires students to learn an enormous amount of information in a very short period of time and make sense of that information in such a way as to pass necessary exams, or you don't get to continue. So in the preclinical years, there is a focus on differentiating between normal and abnormal systems. So in those basic science classes, and then classes around the basis of disease, there's really a lot of discussion, and a lot of the questions are about what is the difference between normal hemoglobin levels and abnormal hemoglobin levels. And if I've been a sub for some problem-based learning, and in which students sort of work as a team to try to get at sort of the medical problem at hand. And much of that is around students identifying what is normal and what is abnormal. So in the clinical years, that's when you're still doing that work, but you're also learning about cure and treatment, how to cure and treat things that are categorized as abnormal. So critical disability studies challenges this. You may or may not be familiar with critical disability studies, but it is in opposition to sort of what health education is based on. So critical disability studies tells us that disability is political, cultural, historical, and it is interrelated with power and oppression. But I think most notably, critical disability studies questions that divide between the normal and the abnormal, between typical and atypical, and really makes the argument that the definition of abnormal only develops when you are relying on a normal, and that often this quote unquote normal is not really, right? It is not actually most typical. It is not the only option. So I think this is a challenge with how our trainees learn about health and healthcare. How can you do both at the same time? Sort of have the existing categories of normal / versus abnormal, these categories of disease and disability, at the same time as we think critically about disability. So bring that lens in that challenges what is normal and questions categories. So to that end, I encourage our med students to think through how they understand disability. What are the conceptual models of disability? And I'm going to review 4 here. These are not the only 4. They may not even be the most important 4. But this is sort of the 101, the disability 101 that sort of gives us the foundation for how people think about disabilities. And so it matters because how you conceptualize disability or think about disability impacts the meaning it has in your life. It impacts how you think it originated, and it heavily impacts how you're going to respond to it. And that's both, as an individual who may have a disability, but also as an individual who provides health care. Now, I do want to stress that these are not mutually exclusive. These can and do overlap. And I think if you think through patient encounters, you will see how they overlap. I'm going to move through these pretty quickly. Many people think about disability through sort of a moral lens. And I don't mean that like this is a moral way of thinking about disability, because I think it's the opposite. I think it's often an unethical way of thinking about disability. But is the idea that disability can be understood as good or bad, good or evil. And it's often, and this is a model that was very, very prevalent before the development of biomedicine, but we still see it. Like you will still hear people talk about disability as a sign of evil in the world. You will hear people with disabilities categorized not just as bad, but also as something good, as a blessing. Like that is also a moral model of disability. Here's a link here to a fantastic talk by a parent of a child with disabilities that I love, about good and bad, and about abandoning a moral model. The medical model is what you are most familiar with. This is really what we highlight for, I mean, it is centered in medical education. It is centered in health education. This is the idea that disability is understood in medical terms. So bodily difference is pathological, abnormal, atypical. So it's those categories that we looked at earlier with sort of what underpins medical education. Disability is the impact or the effect of a health condition, a disease, or a trauma. And in this model, the appropriate response is cure, treatment, or rehabilitation of the individual. And the authorities in this case on disability would be clinicians and medical institutions. The medical model has been challenged by the social model. So the social model of disability, instead of saying that disability is the problem of an individual or a problem of negative difference, here disability is understood as the result of ableism, right? That bodily difference is due to human biological variation. Problems are caused not just by the physical condition itself, but the social conditions that exclude people. And the response here is not necessarily cure, but changing social structures. And Dr. Chandan's going to talk a good deal about universal design. So this really comes out of the social model. For instance, universal design would mean that there's a button on all the buildings so that you could open the door if you were on wheels. In the social model, the authorities on this model are people with disabilities. So this is really taking expertise, not from, but relocating it to people with lived experience, as opposed to people with medical degrees or nursing degrees. The social model is really heavily linked to disability rights movements. In a minute, I'm going to give you some suggestions for reading and books and documentaries that if you're interested in this, that can help orient you, right? But these are examples of times when disability rights activists really pushed publicly so that the law was followed in terms of accessibility. The law was followed in terms of how people with disabilities were treated. There we go. Okay. The functional model brings together the medical model and the social model. One of the problems with the social model is, however accurate it is about a lot of things and about the importance of access and the importance of universal design, what about people who are suffering? What about people who, in fact, desire, need medical intervention in order to live without pain or to live with less pain? So you have this tension between the medical model and the social model that the functional model tries to address. So under this model, disability is biopsychosocial, and it's caused by that interaction between health conditions and the environment. So remember the word biocultural that I talked about earlier. The goal here is to prioritize function, right? So that you meet patient goals, not so that everybody's doing the exact same thing, but so that the patient can do what they want and need to do. So here the authority is shared with healthcare providers and people with disabilities. And Dr. Chandan is going to talk a lot more about this one because it very much is rooted in physiatry, physical medicine and rehab. So as my last point, I just want to show that these models matter because they help us understand why people with disabilities are treated certain ways. So under the moral model, under the medical model, often people with disabilities experience isolation, marginalization, and institutionalization. Under the social model and the functional model, and it's come a long way, the medical model, people with disabilities are integrated into the community and able to exercise their own agency. I want you to think about how this matters, because you will go into clinical settings with a conceptual model of disability. You and your patients and their families are all influenced by multiple models. And so I challenge health education to sort of push beyond the medical model. These are just my little recommendations that I like to share, my favorite disability media things. Crip Camp is an excellent documentary. Code of the Freaks is an excellent documentary about the representation of people with disabilities in film. Crip Camp is a really good one that would orient you to disability rights movements. I love Special. It's a short series about a gay man with cerebral palsy. And then a handful of books. So these are just a few of my favorite disability things that I wanted to share with you. So I'm going to pass it on to Dr. Chandan. I'm going to stop sharing.
Thanks, Dr. Noonan. Let me get my slides pulled up here. I think you guys are seeing my slides now. All right, so I'm basically just going to pick up where Dr. Noonan left off and kind of pick up with these conceptual models of disability. So she kind of went through medical model, social model. I'm going to talk more in depth about the functional model, but one of the things here, I like to point out a couple of things in sort of teaching the medical students and the medical residents. And so one of the first, I think, collaborations that Dr. Noonan and I did together was to realize I had always referred to this problem you see here as diagnostic overshadowing, which is when it's an error in clinical judgment. So it's when it's a bias that a physician or any other clinician might have, where they attribute what is happening at the time always to that disability diagnosis. And so, you know, it'll mess up sort of how you think about diagnosing a patient and therefore what you might pursue in terms of diagnostics, workup, and treatment. And so we see this a lot. So for patients, for example, with Down syndrome, just like my brother, you know, if you go to the emergency room or something like that, there's this tendency to try to tie everything to the fact that he has Down syndrome, when in reality, people with Down syndrome get the flu, they get pneumonia, they get other things just like everybody else. They may be more or less likely to based on their individual characteristics, but it is not to say that the problem is always somehow related to Down syndrome. So in the intellectual and developmental disabilities community, we call that diagnostic overshadowing. I learned from Dr. Noonan there's a similar phenomenon that she taught me about, that is trans broken arm syndrome. So you can see there's this overwhelming sort of thing that groups who are marginalized often see, where a clinician is attributing pathology sort of subconsciously to an identity, as opposed to approaching the patient as you would approach any patient, you know, free of those sort of associations that, as Dr. Noonan pointed out, sometimes come to us by virtue of our training, where we're sort of trained to associate certain things with certain things, and that's just how the shortcuts our brains take. The social model, as she explained, the real, I think, takeaway from this is not shying away from ableism, talking about it, seeing it in our everyday lives, and realizing that, you know, social solutions are required for social problems. The functional model basically ties a little bit of both. This is one of my favorite memes, but so essentially, why don't we just do both? So thinking about both of these, where you see disability and function as outcomes of interactions between these health conditions as well as contextual factors, and we'll get into that. But the goal here, the overall goal in physiatry, physical medicine, and rehab, and should be for medicine overall, is to improve function. And so taking into account both of these things. So the ICF is just an example of this. Many of you have probably heard of sort of ICD-10 codes. ICD-10 is another categorization framework, because again, in medicine, we love categories. The ICF is another one. And so the ICF is essentially a framework to measure health and disability, both at that individual level as well as at the population level. And so it puts every person in a context. And so here, what you see is you have to consider not just say the diagnosis, but what is the physical, social, and attitudinal environment in which people live and conduct their lives, and how are these barriers to or facilitators of a person's functioning. So to give sort of an overview, this is what it looks like if you're trying to think about it sort of visually. So what we usually, talk to the medical students about is right here. This is where medicine traditionally has sort of sat right here, diagnosis. Okay, but there's a lot more to the story when we're talking about a particular patient. So environmental factors. So this is really where you bring into some of the knowledge on social determinants of health, as well as built environment. And I mean built in physical, sensory, and cognitive aspects. And then here you kind of think about MOCE. So physicians, because again, that's where my background is. So that's where I tend to think. We usually live over here. I am thankful that I work in the rehab hospital. And so I always have teammates that are experts when it comes to thinking about this, as well as participation in society. And so really all of these things are important to the patients that we see. And so being sort of knowledgeable, if this is sort of home base for us, but being knowledgeable about other clinicians that specialize in these areas and how we work together as a team. So again, that's where we're used to thinking. So applying this here, here's an example. So a way to apply this, and our residents sort of get tested on if they're able to think in this way. So a patient with a spinal cord injury, here's those personal characteristics. So male, 30 years old, environmental factors. Here you've got your body structures. These are activities. So activities that this particular patient may have difficulty with, and that then leads to difficulties in participation. And so thinking all throughout here, how can we improve this to improve this to improve this? But again, it's to help them sort of maximize function, maximize independence. And so this also matters, like I said, in terms of interprofessional practice. And so what you'll see here is ultimately, in order to take care of a patient, any patient, particularly a patient with disability, really any patient, you should be thinking about what can other disciplines bring to the table? Because in no world is medicine going to address everything that is of importance to patients. And so partnering is incredibly important. So we spend a lot of time. My favorite question to ask the medical students is, what is the difference between PT and OT? And they don't know, and that's okay. People don't usually know until they get well into residency if they're in physical medicine and rehab. And if not, we make sure to talk about that with the students so they have an understanding of, again, that interprofessional collaborative practice. And so Dr. Noonan, I think, really addressed this well in terms of, well, why do we care? The students, they're like, is this on boards? No. Okay. Well, why do I care about how I think about disability? And the answer here is it's important for a lot of reasons, from the medical, research, administrative, and disability rights perspectives. And for us, if I'm speaking to faculty, I say, really, you have to remember that how you think about disability has implications for the clinical care you provide, but also research. Dr. Noonan mentioned the questions you might ask or might not ask, depending on how you're thinking about disability, as well as teaching. So I brought up Unlearning here because I see that this is sort of a paradigm within medical education right now. And so some of this unlearning is critical when it comes to ableism and thinking about people with disabilities. And so an exercise that you are welcome to steal that I like to go through with my students is I'll describe a patient. So I will say 38-year-old male, has worked at the Atlanta VA for over 20 years, has taught himself Spanish, he plays piano, has a very active social life. Is this person disabled? And overwhelmingly, everyone's like, no. And in a medical model, those are your only choices, yes or no. And so no is usually what I get when I describe this patient. But you'll see with the ICF, it requires a deeper dive. So disability here is not equated with just the medical condition or diagnosis. We talked about the importance of environment and context there. So when I then tell my students, okay, this same patient I just told you about, this patient has Down syndrome. Now, is this person disabled? And then they kind of just look at me like, well, like I said, no, but. And so again, the ICF is helpful to kind of start some of those conversations about taking a deeper dive into functional status, as well as disability, and seeing, what are the factors there. And it's not something that is a one-to-one relationship with a particular diagnosis. And so realizing that. Dr. Noonan covered ableism and intersectionality, so I'll just briefly touch on those, but I think those are really sort of core foundational concepts from the social model that need more integration into health education. And so thinking about it from this way, we kind of mentioned disability versus disease and illness. And so attitudinal barrier I see in the chat. Yeah, we're gonna get to that. So how bad is the attitudinal barrier? How bad is the problem? Unfortunately, it's pretty significant. We'll get to a study in a little bit that sort of illustrates that. But one of the first steps in educating is disability. Again, it's that diagnosis plus environment. And when I say built environment, I often have to stress, I don't just mean physical accessibility. It's incredibly important, but there's other forms of accessibility, cognitive as well as sensory. And then the attitudinal environment as well. So when we say the environment, we're really asking people to think about all of these things. And when we're creating environments, we should be mindful of all of these types of accessibility. And so, one question we ask the students to reflect on is, how are clinicians part of a healthcare's environment, a patient's healthcare environment? And I would ask, so for students with disabilities, there's really sort of two environments that students with disabilities are going to have to experience. One is the medical school environment, and Dr. Noonan and I have talked about that, within the building. That's one environment, and there's some things that can be sort of built in, more control over that environment. And then there's the broader health system environment. And the broader health system is not accessible at all for patients, much less for learners. And so those require additional conversations. And I think that's why representation in the workforce is so important. So the more we have health profession students as well as health professionals with disabilities, the more we're going to be able to learn from their lived experience and evaluate our health system, those healthcare environments. So this is the study I mentioned. This is a pretty landmark study, which I want to say it was surprising, but honestly, it wasn't. It was in 2021, but I think it gave us, in the language of academia, like it gave us a citation for the things that we've been saying all along. So that was kind of nice. Physicians' perceptions of people with disability and their healthcare. So again, this is thinking about patients with disabilities, not necessarily students, but let's think about how that cross applies. So it's really looking at ableism. They don't quite call it that, but it's looking at that as a determinant of healthcare disparities and saying that, ADA been around since 1990, but these findings about physicians' perceptions about patients with disabilities raises questions about whether we truly can have equitable care for people with disabilities. So what were those findings? Well, it was a survey of 714 practicing physicians nationwide. They actually excluded physical medicine and rehabilitation physicians because they said that these physicians should have better attitudes towards patients with disabilities. We had a very high level conversation at our academy meeting on, are we worthy of that designation? We have a lot more work to do. Everyone does, truly. But it sort of was, I think, a helpful thing for our field of medicine to say, we're supposed to be, sort of leaders in this area. Are we answering the call? Where are we falling short? What can we do? But you see the findings here. And so you can see how if these are overwhelmingly the attitudes that physicians have towards patients with disabilities, and so these potentially biased views could contribute to persistent healthcare disparities, then I wonder, well, how do ableist views among physicians affect health education? And it is so deeply entrenched, particularly in that second environment that I mentioned, sort of the healthcare environment itself. How do we get around that? And it's going to take a lot of conversation. And I said, ultimately, it's learning from physicians with disabilities and sort of supporting that diversity in the workforce and listening to them when it comes to thinking about how to make things more accessible. Dr. Noonan covered this already. I want to talk a little bit about what does, ableism, so what might that look like? Lack of compliance with laws like the ADA, merely aiming for just compliance with the ADA is in and of itself ableist. We'll talk more about why. Failing to incorporate accessibility into built environments. So Dr. Noonan shared a story there. Restricting treatment choices based on a disability diagnosis. So I highlighted this because as a physician, I see this all the time and it's concerning. Again, it shouldn't be something that limits treatment choices. We've seen this a lot with COVID-19. There's lots of papers out there as to how this came to be. It was I think it was so problematic that there's now sort of legislation and things aimed at getting rid of that quality of life designation because it was being used to ration care. So in a situation such as a pandemic, where there are not enough resources for the need, get into care rationing, and people with disabilities are often first to be sort of, on the chopping block, so to say, as to not receive those vital services. And it's often justified in sort of a quality of life way, as in, oh, the quality of life for this patient isn't as good. You saw the bias from the study I quoted earlier, where we know that that's a known thing. So anyway, there's a lot of work being done right now to address this in the policy world. You'll also see ableism in both verbal and nonverbal communication. So if you listen for it, it's there. I think I myself am particularly attuned to it because of my older brother. I think disability is also incredibly complex because, as Dr. Noonan mentioned, it's 1 in 4 adults in the United States. It is an identity that people can either choose to disclose or not disclose, depending on which type of disability they had. She showed you that umbrella. So this encompasses a lot of different types of people with different lived experiences. And what you'll find is even in the disability community, there's sort of infighting there. I'll give you the example of I, as a trainee, as a medical student, was doing an away rotation, and it was in pediatric physical medicine and rehab. There was a family with a child, maybe 2 or 3, and so the physician who has a physical disability was consoling the parents, providing guidance, and said something to the effect of, well, it could be worse. At least your child is not our word. And I almost burst into tears and had to excuse myself, and then later confronted that attending, got into some trouble for it because they were a senior, but said, I am a sister of an older brother with Down syndrome, and I think your ableism is showing. If you were going to now compare people with disabilities to each other and try to rank who is better, or again, that moral model coming out in very strange ways. So again, this is a talk we often have to have, even within disability community and allies, to say, oh, we really have to check ourselves even for looking at ableism. Here's an example of just, the sort of nonverbal communication. So Accessible Icon Project, you can check it out. But the idea is that even symbols sort of communicate something to us about about how we view a certain population. So you can see on the left here, and equating that symbol with sort of the term handicapped, which there's interesting history there. But then on the right, sort of more active, engaged part of society, and discussing it more in terms of accessible versus not accessible. So just bringing that up there. You can also see it in policy. So I mentioned the R word. There's a lot more detail with that, but here's a law that came in 2010 under the Obama administration that was for federal policy. So we're seeing sort of shifts there. And then, the age-old terms of wheelchair-bound and wheelchair-dependent. Part of this is talking to students, health profession students, to say, okay, well, what does it communicate when you use that term? And let's pick a different piece of equipment. Would you call me glasses-bound? Would you call me glasses-dependent? And of course, they're like, well, no, why? And I said, well, what's the difference? This is a piece of equipment. That's a piece of equipment. What's the difference here? So again, I use glasses. They use wheelchairs. And so thinking through what are the messages we've gotten through the years that cause us to have these views, which sort of manifest in communicating in a particular way. I bring this up too because this is tying back to when Dr. Noonan mentioned intersectionality. So there's a charge in the disability community as well to say that, okay, even if people with disabilities are invited to the table, it doesn't represent the diversity of the disability community itself. Because again, if that's 1 in 4 adults in the United States, what other forms of discrimination might people with disabilities experience? They can't separate, like their disability identity from other identities they may have. And so important to realize that these silos that we have when it comes to, patient populations or research, they don't exist when someone is living their life. I always use my daughter sort of as an example, but my daughter is at the same time, she's Indian as well as Jewish. And so as she lives her life, she doesn't identify, with only one or certain, it's a different identity altogether. And so understanding that intersection of identities requires active listening. And that's really critical for understanding these barriers and facilitators to equity. And so we talk through that as well with the students. Now, and again, Dr. Noonan kind of gave the definition and everything here, but what I want you to kind of take away is that for people with disabilities, so marginalization because of disability or the impact of ableism is then compounded by other forms of discrimination that we see. And so it often amounts to, when we're looking at the health disparities research, essentially sort of a double burden. So being cognizant of that. Let's see. So I highlight number 2 here. This is 3 responsibilities of clinicians to disability communities. It's sort of a helpful framework, I find. It's from the AMA Journal of Ethics. We kind of talked through ableism, number 1, number 2, communication. So I'll give you sort of a snippet of what we tried to cover with the students, but you'll notice here, speaking of ableism, where it shows up, thinking about language, responsibility to communicate better with and about patients with disabilities. Yes, but also colleagues. A lot of the time, if disability is represented, it's represented as a characteristic of patients, not acknowledging the fact that physicians themselves, clinicians themselves can have disabilities. Highly recommend on Twitter, Docs with Disabilities, Future Docs with Disabilities, following them. There's also going to be a health equity journal supplement that I was able to guest edit that's coming out that has, I think, 8 different perspectives pieces from variety of different people, but 2 of them are physicians with disabilities. And so it really, I think, speaks volumes more than a journal, a study, I guess you could read, because that lived experience is so rich. And this 3rd part is a bit about that lived experience as well. So communication. So, again, how do we communicate to patients with disabilities, about patients with disabilities, to colleagues, to learners? This is an opportunity. I bring this up only to show you sort of intersectionality in practice. So when we are doing disability education, we talk about person first language versus identity first language. And you'll hear me use both, because I'm not a member of the disability community, but I am acknowledging the fact that there are preferences there. In particular communities, so in the deaf community, oftentimes the preferred identity is deaf with a capital D, same with autistic. And so otherwise there's person first language. So the intersectional opportunity here is pronouns. And so Dr. Noonan and I partnering together, I've been really fortunate that when we are addressing one form of discrimination in teaching or in clinical care, we strongly feel you can and you should address others. And so that collaboration interprofessionally, again, is so critical. And this is just sort of a summary of what we talk about when we have these conversations with learners, to say, okay, let's talk a little bit. How do you ask somebody about this? Well, depends on what we're talking about. This is sort of the art of medicine, or it's not something I can just give you a checklist and then you sort of awkwardly ask patients. Like, that's not the way to do this. but humility is very important. So, being able to say, I'm learning, I'm not part of this community, please teach me, I want to do better, is not a bad place to start. And again, that active listening. So that health equity supplement that I mentioned has variety of perspectives pieces paired with discussion questions to have some active dialogue back and forth. Dr. Noonan actually wrote a piece for that supplement. So excited for that to come out soon. But essentially, the goal here is, you need to ask people, don't assume things. So again, the lived experience. I think there's a recognition now that in medicine, again, that's sort of where I'm most familiar, but marginalization will occur when professionally trained people, several physicians, are positioned as experts about forms of life of which they have no lived experience. And so recognition truly is needed by able-bodied clinicians as well as elevating disabled physicians. And being very intentional of that, because again, disability means such a broad umbrella, as Dr. Noonan showed you. There are people with disabilities by nature of their disability, like my brother, who will not be part of the physician workforce. And so if we are only taking physicians with disabilities as sort of the spokespeople, the ideal for people with disabilities, it does not replace that. And so again, there's this balance here of supporting disabled physicians and also recognizing that disabled physicians do not speak for the broader population of people with disabilities any more than physicians speak for the general population. So being conscious of that. Nothing about us without us is the mantra of the disability rights movement, and I think a helpful thing to keep in mind. So again, elevating self-advocates. So these are just a little snapshot of what education looks like about disability. So no requirement for medical schools. 81% of graduating students have said that they've received no training when it comes to intellectual and developmental disability. Average training, if it occurs, is about 1 hour, usually in pediatrics. You can see how that's not sufficient for a population of people with IDD who live well into adulthood. On the dental side, the National Council on Disability, who I'll mention again briefly, worked on sort of this code of professional conduct, as well as changing the actual accreditation standards. This is a topic in and of itself, but just wanted to sort of bring awareness to this because from a policy perspective, it gives us in medicine something to latch on to say, well, dentistry did it. So we need to get with the times, I guess. So ADA compliance. So the ADA, I thought the best way to summarize it is this timeline here. And you'll notice this is kind of all people think about when they're thinking about the ADA. They're like, there's some stuff and we were working on it for a while and then it passed in 1990, done. And usually that's what people think is, we don't need to talk about disability. We solved that with the ADA and we solved that quite a while ago now in 1990. But in reality, what happened after that, you'll see a couple of Supreme Court cases here. This last one here was actually in Kentucky. So it was Toyota in Kentucky. And what happened is these series of court cases sort of weakened the ADA to the point where it essentially put people with disabilities in this catch-22. A lot of the sort of verbiage centered around the definition of disability. And so unlike in other situations where if there's discrimination based on a particular demographic characteristic, people with disabilities were having to prove that they were disabled enough. And so it turned into a catch-22 where if you're too disabled, you might not get the job. If you're not disabled enough, you won't be covered under the ADA. And so it was problematic in terms of the interpretation. And so then NCD, National Council on Disability, made a recommendation here in 2004. Eventually, after a lot of advocacy, there were amendments that were passed in 2008. And again, not going to go into the full details there, but I just like people to realize that this is something in the policy realm that continues to be relevant. The story is not done, and there's a lot more to be done, in fact. And so just wanted to mention that. So best practices, one Dr. Noonan mentioned is universal design. And so that goes beyond just compliance with the ADA. And I like this quote here. it's about going beyond compliance in terms of what the ADA really means and what it means in terms of disability and inclusivity. And so we talked about with that, and thinking about how we think about disability, thinking about that environment, universal design does just that. And so here is a comic that I think illustrates it pretty well, where, someone is shoveling stairs and there's also a ramp, and the person using a wheelchair says, "Could you please shovel the ramp?" And then the person shoveling snow says, "Well, all these other kids are waiting to use the stairs, so let me do that first, then I'll clear it for you." And the person here astutely notes, "But if you shovel the ramp, we could all get in." So again, universal design is essentially thinking about designing products and environments to be usable by all people to the greatest extent possible without needing to adapt or have a specialized design. It empowers and enables a diverse population by improving health, wellness, social participation. So the idea is, if you are thinking, I'm going to create this patient education handout, for example, and then I'm going to adapt it in like 6 different ways to make it usable for other populations. That's not it's a shift of thinking about it in a different way. How can I design this such that it is usable by all? A colleague of mine at University of Kentucky, and I'll provide her contact information, is one of the experts in universal design and has come up with a simple way of thinking about it, but using multiple methods, simplifying, and very importantly, testing it out are key principles of universal design. And so I always say, consult the experts, the intended population. If you're trying to design, say, a clinic building, ask somebody who uses a wheelchair to come do, to come through and to tell you, rather than trying to read the manual and make sure, there are things they will tell you, like the door switches, that are not part of ADA compliance in sort of the building design manual, but are incredibly important for meaningful use of that environment. So this is Lindsay, and this is their website, and they do a lot with universal design in terms of cross disability. So like I said, physical, cognitive, and sensory environments, thinking through that. The last sort of best practice I'll leave you with is using this lens of equity. So we've recognized in medicine, health is not just the lack of illness. It is so much more than that. I think next what we need to see is meaningful inclusion being as more than just a lack of discrimination. So with the ADA sort of centered on compliance and discrimination, that's good. It's a good start, but certainly there's much more to that. And so on the policy side, I encourage you to check out the NCD is the National Council on Disability. And so they were formed in 1978. They are the independent federal agency that's charged with advising the president, Congress, other federal agencies, and played a pivotal part in the ADA and in advocating for amendments to the ADA when it wasn't sort of fulfilling its original intent. They have recently as about like a month ago, put out their health equity framework. And I think that this does a really good job of taking sort of the complexity of the disability community and whittling it down to say, okay, these are the 4 core components that if we could address these, it would go a long way in improving health outcomes for patients with disabilities. It would also make the workforce more inclusive of people with disabilities. And so you see here, there's sort of clinical, you'll note it says clinical care curricula. So we're not talking about communication, skills you may learn in the first 2 years. Those are important, but the assumption here is, again, that's sort of the minimum. You should definitely be doing that. But then you need to be talking about disability clinical care. So how do you ensure that people with disabilities who say use a wheelchair receive the appropriate preventative care? You don't just not do it because that patient needs to come out of their wheelchair to do the exam. So making sure that that is something that is actually taught and required for all physicians, regardless of which field they go into. You see accessible medical diagnostic equipment here. I love this one because that means accessible for patients, but also for physicians with disabilities, the ability to move the exam table up and down. Key features there in the equipment that we use would enhance accessibility, not just for our patients, but for our colleagues as well. Improved data capturing. So this goes back to that umbrella slide that Dr. Noonan showed you at the beginning in terms of disability being this broad category. We don't capture disability consistently. If we do capture it, we don't capture it in the same way. And so people with disabilities are often lost in data collection. This happens quite frequently with intellectual and developmental disability, where sometimes if disability is captured, it's meant to include only physical disability, and then you lose so much more of the actual disability population. So standardizing, improving data capture across agencies is important. And then the special medically underserved population designation. So this is a big one, but just as sort of a two-liner, it's essentially referring to reimbursement. So for physicians, if you are practicing in a medically underserved population area, you can qualify for loan repayment. There's also different incentives and things that come with that designation. Disability does not qualify. And it's because the formula that is used by HRSA looks at the demographic characteristic within a particular geographically defined area. And because people with disabilities are 1 in 4 people and are spread out across the United States, they don't qualify in terms of that concentration in a specific geographic location. So there's a lot of work being done for this that's been in progress for a while, but there's sort of renewed charge around this after what we've seen with COVID-19. So highly recommend checking out this health equity framework. I think it lays out and interfaces nicely with health equity more broadly. And like I said, is intersectional in thinking about disability, but also how does it intersect with other forms of discrimination and other health disparities that exist. So I believe, yeah, that's all I had. So I will stop sharing and we can, I guess, transition to questions.
Oh, Jess, I think you're muted.
I caught it. I have 2 mutes. I have a microphone in front of me and a button on my screen, and I usually hit one or the other, but I always forget one of them. I do see that Janet has her hand up. Would you like to unmute, or would you like us to revisit I think you saw had a question in the chat already.
Oh, I don't know. Is my microphone off?
We can
On?
hear you.
Oh, yay. Okay. So first of all, thank you so very much. I have been, for the last 13 years, a health mentor for the interprofessional education, for different types of physicians in different hospitals. Now I have a very fancy title, lived experience expert advisor, but I'm a patient. And most recently, and also a disability justice advocate. So I can appreciate the different 4 models that you propose, but and I see that you use quite a few of the principles, the 10 principles of disability justice are reflected there, specifically intersectionality. And my question directly is, how much resistance do you encounter with those who are creating curricula for medical students specifically? And if you have any strategy. The reason I'm asking is that I was invited as a patient to bring input for changes in the curriculum of Faculty of Medicine. So that I think I'm in a very special moment, and I would like some help.
Priya,
Well,
do you wanna
Dr. Noonan,
start?
do you want to introduce our other hats, or you want me to do?
You go ahead and start, and then I'll add.
Okay. So we appreciate your question, and yes, there can be sort of pushback. Dr. Noonan and I are also both co-directors of the National Curriculum Initiative in Developmental Medicine. So that's an initiative where, much like you're saying, we push for curriculum about the funding is for intellectual and developmental disability, but we use it as an opportunity to be cross disability in nature. But the requirements are that it is community engaged, so you have to have community partners, and there's, different goals and objectives that we go through. But in terms of pushback, honestly, I think it's an opportune time now with health equity is sort of on the radar of medical schools and as an overarching umbrella. I think the challenge in medical education is always time. Dr. Noonan mentioned, there's a lot of information in a short amount of time. But so what I tell our disability advocates is be creative, ask them for any time, because really I can talk about disability on any lecture you'll give me. They gave me the Medicare and Medicaid lecture because it's one most people don't really love to talk about it, but I was pleased and thrilled because that is the perfect time to talk about patients with disabilities when we're thinking about healthcare financing. So really, when you go to them and you say, what topic do you need help with? You can absolutely apply, the lens of disability and address what the medical school needs, but also address the important considerations that I think we see with patients with disabilities and colleagues with disabilities. But we're happy to connect and talk more, specifically for support for you offline. But just wanted to mention that. Dr. Noonan, I don't know if you've got any thoughts you'd like to share.
I can give some specific examples. So I sort of accidentally ended up in this position doing research on LGBTQ plus health, which I love. It is and is important. But over the last 6-ish years, had more opportunity to be involved in other things. And there are many areas where disability works as a case study or a way to focus on something. So like, even though medical schools are not required to, train people on, intellectual and developmental disability for a certain number of hours, they are required to, show that they're training students on cultural competence. You can bring in, disability cultural competence. And I would like to push beyond cultural competence to cultural humility. But, so in the past have used that as an example of, what cultural competence and cultural humility looks like. Another example would be, schools are required to teach about interprofessional education. So we developed a panel that is really about, Priya was talking about, the difference between PTs and OTs. And it brings in, physical med and rehab doctors, but also OTs, PTs, speech therapists, who talk about the work that they do together as an interprofessional team. But also this teaches students about sort of the world of like post-acute care for people with disabilities. Mm-hmm. Mm-hmm. And we also try to bring in people with disabilities to those sessions. So
thank you.
Great, thank you so much. Emily, could you go ahead and elaborate on what, I do see that somebody has their hand up, but elaborate on trans broken arm syndrome for us.
Yeah, so Janet, I saw your question on that. So trans broken arm syndrome was coined, I think, in around 2015. It was in a British LGBTQ publication. It was a journalist, I think, or a blogger. And it's the idea that when a transgender person seeks medical care, the only thing the doctor sees is the fact that they are transgender or that they're on hormones. So, I mean, and there are indeed cases where people go in the emergency room or urgent care with a sore throat and the doctor's like, I don't know how to treat you, you're on hormones. Like, dude, like do a strep test, right? Or, you have a broken arm, well, you don't need a full body exam, or details, like real details about your surgical history for a broken arm. Like your physician needs to know some things, but it doesn't need to be focused around, being transgender or being on hormones or having received gender affirming care. So that's what trans broken arm syndrome means, just that focus on gender identity, despite whatever else is going on.
Great, thank you. So I believe that's Vida who has her hand up if she'd like to unmute.
It is Vida. And first, just thank you so much to Dr. Chandan and Dr. Noonan. Excellent, excellent informative presentation. So So wonderful. And so many principles that actually cross so many levels of discrimination, and we all have these laws and we think, oh, well, we have that law, but, like a one and done, and instead of a process. So my question or concern actually is to the burden that an individual or a caregiver family carries to prove worthiness of support. And I see that within my family and my neighbors who have special cares needed, but they somehow have to prove that their family member or their child fits some kind of definition of what is worthy of that state help, or that education support, or that accessibility, or that wheelchair, or that special bed. And the paperwork is enough to drive you insane. And I see these wonderful families, and just so you have the laws in place, but to get to those services is problematic in and of itself. And I realize that there need to be checks and balances, that, resources are limited. However, and I even experienced that on a very minor and able situation of trying to get, and Jessica will speak to this, trying to just get a push button for the restroom in in our building. But it's like, well, does anybody really need it? And the point being, we don't know if anybody needs it, because they're probably not using it because they can't, or to get to that space. So we don't know who's not using it because they don't use it. So I feel like the responsibility or the onus to be able to prove a value or prove a worth or prove that you're fit for it is a real problem associated with this environment and I would say in many discriminative environments. It's like somehow I have to prove I'm worthy of your attention. Have you experienced that?
Yeah, Priya, I don't know if you want to take that from a policy perspective.
I think if you go first, I mean, as a person with
Yeah.
a disability, you speak to your lived experience, I'll talk about it from the caregiver side for sure.
Yeah, sure. So it's, you're absolutely right. And, I've seen this in sort of various areas of my life, from, when I was in high school, seeking vocational rehab assistance. So, that was, somebody, I was never going to make a living doing physical labor, right? That was not going to work. So the idea of vocational rehab is to give people with disabilities the training that they need, or the college education that they need to be employed and employable. And, so I remember, sort of in high school, this process of, showing, how disabled I was. And I was really only disabled enough to get money for books, not for my tuition. So, but, other people I know, they were disabled enough to get a lot more assistance. And, have seen the processes that family members go through trying to get on disability. It's absolutely horrific. And my solution, my thought is that, there is in fact enough to go around. And if we cut out all the paperwork and everybody has access to healthcare, to basic healthcare and housing and food and potable water, then we would in fact have a lot more money to spend on those things instead of paperwork about those things.
Yeah, I'll just add to that I think that what we've seen, so as a sibling, I've always thought about people with disabilities as my friend. That's part of my world. It is very easy for a lot of people to say, I was shocked in med school when we sat down and it was who has met somebody with Down syndrome? And there was 2 of us. And I was like, where have you guys been? Why, what do you mean you haven't? I don't even understand. But I think that honestly, I'm hopeful that things if that's a silver lining we can take from the pandemic, I sure hope so. Because I think more and more people are seeing, there's been a lot of discussion as to the polio epidemic and sort of what that did for the disability rights movement and how it created disability advocates. And is that what we're going to see And I hope so, but I will say, so as a physiatrist, patients who've had a life-altering illness or injury, they're often very unaware of how not set up the system is for people with disabilities until they have one themselves. And so, I'll give you an example. Like, I can't tell you how many times a week we hear patients say, like, but I had a stroke. What do you mean they don't cover the ramp? And we're like, we know, like, we wish it was different. Like, I know. And they're like, has it always been this way? And you're like, yeah. And they're like, it's just nobody really sees it until it affects them. But I'm sort of hopeful that moving forward, maybe it's not about if you need the push button or if you need this sort of thing, but if it's something that improves accessibility for the community, then it's something worth investing in.
And I think that lends itself to the fact and the reality that the fight isn't over, and that there have been steps and achievements and advances in the work, but we still have so much to go and so much to do. And we all need to be part of that. We need to be part of those talking points.
We talk about it in the Medicaid Medicare lecture. Again, it's sort of assumed, just like it's assumed ADA is a policy, it passed, like, good, we're great, it's solved. Medicaid and Medicare, it's the same thing where everyone's like, well, that takes care, it's taught as, and this is what provides for people with disabilities. But the reality is it doesn't cover their needs. And, I have colleagues and friends that have been on the waiting list here in Kentucky since they were 2, and now they're in their 30s and they're still on the waiting list. So trying to educate people as much as possible that, don't just assume that, check, like it's been solved, because it really hasn't. So
I think that's a good point. We've got 4 minutes left. So I'm going to ask, if going off what Vida mentioned, what do you each see as, kind of to help frame your closing thoughts, what do you see as on next step for the people who are here today, who have attended this session? What would you like them to take away, or maybe an action they could take on some kind of micro level? What can be done to meet those challenges, that the path we still have, the way we still have to go?
My go-to is to think critically. So the next time you're in a lecture and you're learning about a specific diagnosis or a specific disease process, and you hear the word abnormal or atypical, think about what that means. But especially think about what that means when you're talking not necessarily about a lab value, but about a human person. So, what perspective, what is the conceptual model of disability that is being presented if in what you are learning? And think critically about that, and then ask questions, of your peers, of your faculty, about that might center another way of understanding disability.
I guess my takeaway would be, again, with sort of the renewed focus on equity and health equity coming out of the pandemic, is just to say that include disability in those discussions. It's often not. It's so in the NIH, I'm going to blank on the right acronym, but NIMHD, the sort of framework for minority health, disability is not included. It's considered a sort of a moderating thing that affects every other identity. So they're like, it's not covered. It's not intentionally called out because it's part of everything. But if you're part of everything, you're part of nothing. So being sort of intentional and inviting people with disabilities to the table in any of those places where you are sort of a gatekeeper in those conversations on equity.
Wonderful. Well, thank you both so much once again. Thank you for everybody who joined us. We do have the CECME code in the chat, and I'm just making sure those are clapping hands. You're getting applause in the chat, and making sure those are clappy hands and not raisy hands. But you do have a CME code in the chat and a survey to fill out. Let us know what you would like to see more discussions on, how you felt about this one. And we do take all that feedback into consideration when we're planning these things. That really helps out. So thank you, everybody. Have a good evening.
And just to, I think, Jessica, you might have said that the link will be available. This is going to be embedded within our collection, so it can be shared and used. Thank you.
Thank you all.
Thank you all.
Thanks, everyone.